internal brace and progressive collapsing foot. What are we going to talk about? About anatomopathology of the flat foot, about soft tissue procedure, and when and how to use the internal brace. The most important dynamic stabilizer of the medial arch, as we know, is the tibialis posterior tendon. And according to the dysfunction of the tibialis posterior, we have a different classification. In stage 1, usually we don't need surgery. In stage 2A, we have partial tear of the posterior tibialis tendon. In stage 2B, we have sometimes a complete tear. But in the last year, we discovered one of the second actor of the flat foot instability, which is the spring ligament. Spring ligament is, in reality, the calcaneonavicular ligament, which has two portions, the inferior and the superior medial. And this is the main static stabilizer of the medial arch of the foot. And its function is to keep the head of the talus in its position. And when we have the collapsing or the injury of the spring ligament, we have a progressive collapsing of the arch and as well a forefoot abduction. And we can see with the too many toes sign. So we have at least 2 points of failure in the medial column, the tibia, the posterior tibialis tendon, and the spring ligament. What comes first, chicken or egg? We don't know. Probably it's a degenerative changes in both, in tendon and in the spring ligament. But at the end, we have this situation with a collapsive flat foot and a forefoot abduction. And we can see also in the MRI, and the incidence of injury in MRI is very high, both for tendon and both for ligament. How can we correct? We can do bone procedure. Generally, the most common is the medial displacement calcaneal osteotomy, or MCO, or we can perform tendon transfer. And the most common is flexor digitorum longus, Latin pronunciation, sorry, transfer to the navicular. And this is a classic situation. Here you can see the lesion of the spring ligament, the navicular tuberosity, and the tibialis posterior tendon, which is usually degenerate. So which is the goal of this treatment? To reconstruct the spring ligament or to repair. If we repair, a direct repair usually is not enough, so we need a reinforcement, and in this case, the use of the internal brace is crucial. We all know what is internal brace. I knew this man for the first time a lot of years ago, but with the same kilt, with the same attire. And this is the internal brace kit. How to use? We have two strains. The inferior strain goes down inside with the tendon, the flexor digitorum longus tendon, and the superior strains go from upside to down, and then finally fixed into the navicular. So we have two options. If we have a complete lesion of the tibialis posterior, we have to perform FDL transfer and internal brace. If we have a partial lesion, we can use the remaining part of the tibial tendon and apply the internal brace without sacrifice the flexor digitorum longus. And this is one of the typical situations in which the tibialis posterior is completely gone. We made the harvest of the flexor digitorum longus just before the Henry note, fix the big anchor, the grain anchor, just inferiorly to the substentaculum tali into the calcaneus, and you can check the position with the scope, with the fluoroscope, and then make the complete tunnel in the navicular bone and pass the tendon and the two strains of the internal brace and just fix to the navicular bone. This is another case with partial lesion, but the tibialis posterior is still good enough. So we decided just to use the internal brace to reinforce the suture of the spring ligament. And in this case, we use, as shown before, the small screws like an interference screws. Which is the postoperative care. If we perform soft tissue procedure without bony, which is, I have to be honest, is really a rare situation in young patients, the cast is just for 1 week without weight bearing, at 8 days progressive weight bearing with ankle brace, and the beginning of the physiotherapy only in flexion and extension, avoiding pronation and supination. And at 4 weeks, we give the complete range of motion. If we perform also bony procedure, of course, the healing of the bone is another question, and so cast for 4 weeks without weight bearing, at 30 days progressive weight bearing, and physiotherapy as in the other case. This is our experience, and now we have performed more than 70 procedure, but this 47 patient was done years ago because we would like to check it at the minimum follow-up of 2 years. And the associated procedure, as you can see, were flexor digitorum langon transfer in 65% and medialization osteotomy of the calcaneum in 70%. Just one case, this is a young male, 51 years old, with a progressive flat foot. As you can see, the initial arthritic changes also in the Chopard joint. We performed both medial calcaneal osteotomy and spring ligament reconstruction with internal brace and FTL transfer. And this is the result. At 6 months, we recovered the coverage of the talar head, and we recovered also the normal medial arch. So in conclusion, the internal brace represent a reliable system for the reconstruction of the spring ligament, even in presence of degenerated ligamentous, and it can use as a reinforcement also in the treatment of tibialis posterior tendon injury. But the treatment of the posterior tibialis tendon and the spring ligament in flat foot has to be associated generally with hindfoot realignment bony procedure. So thanks, and I would like to invite you to the next Winter Olympic Games, which will be held just near here. Thanks.